Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra Season 3. Doctor, as monsoon season has started 1.5 month back and it has taken the whole India into its grasp, and we wanted to raise awareness about a group of serious medical conditions which comes under the umbrella of tropical fevers. These are diseases which affect population of tropical and subtropical region like India, and and in the clinical setting, July to October, November months are heavy OPD fever months. So hence we wanted to, so hence we planned a 6 lecture series especially for managing tropical fever in India. Today's topic is acute tropical fevers, and today's session is brought to you by your zero calorie hydration partner Inazal Zero. And before moving forward, I would like to announce the last week quiz winners. Dr. Daud Khan from Bangalore, Dr. Rajiv Handa from Delhi, Dr. Bharat Praveen Mittakota from Surat, Dr. Sanjay Malhotra from Lucknow, Dr. Gangadhar Rath from Bhubaneswar, Dr. Fareed Khimani from Mumbai, Dr. Pradeep Pathade from Vashi, Dr. Shashi Khare from Bhopal, Dr. Pradeep Patro from Chhatarpur, Dr. Vinay Desai from Tumkur, Dr. Ashwani Kumar from Kanpur, Dr. Bimla Kapoor from South Delhi, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Ramesh Hegde from Bangalore, Dr. Vilas Sonavane from Atisti, Maharashtra, Dr. K. Parvatha Vardhini from Bangalore, Dr. Anand Purande from Mumbai, Dr. Satish Kumar Jain from Bangalore, Dr. M.R. Chipa from Barmer, Dr. Vijay Agrawal from Pune, Dr. Praveen Thakkar from Vadodara, Dr. Sanjeev Puri from Hoshiarpur, Dr. Supriya Dhamble from Pune, Dr. Lakshman Chavda from Rajkot, Dr. Lakshmipati Bhupati from Vellore, Dr. Ravi Bhatt from Sirsi, and Dr. Sumita Sharma from New Delhi. So thank you all the doctors to take part in our quiz. Now I would like to welcome our host Dr. Sanjay Kalra to enlighten us regarding today's topic. Dr. Sanjay Kalra is President South Asian Federation of Endocrine Society. Thank you so much, sir. Over to you, sir.
Thank you, Ankur, and good evening, everyone. All of us are logged in, and this is Diabetes Essentials Season 3 going on. But when we manage diabetes in the clinic, we have to manage many things, much more than glucose. And one of the complaints that our patients are presenting to us these days with is fever. So that's why we thought we'd talk about tropical fevers. Now, there are different kinds of fever. Some of us, we have experienced another kind of a fever. It's called Ishq ka bukhar. Our speaker will be speaking on that as well. But when you speak about Ishq ka bukhar, that is, it's 24 by 7, uh, 12 months in a year. It can occur at any time. It can actually occur at any phase of life also, irrespective of what the poets say. So that is something we can discuss anytime. But when you talk about the Jismani bukhar, that is the Jismani garmi or the tropical fevers, these occur in a seasonal pattern. And like Ankur said, since this is the season of fever, we thought we'd focus on this. So a warm welcome to Dr. Suneet Verma, our guest for today. Dr. Suneet is a well-renowned physician working at Alchemist Hospital in Panchkula and also at Spurs Clinic in Zirakpur. Uh, he has expertise in diabetes and also in managing critical care. And he'll be speaking to us about tropical fevers. Dr. Suneet, while we were introducing you, just before that, we were speaking about different types of fever and bukhar. What's your personal experience?
Good evening all. Good evening sir. So आपने explain कर दिया sir.
So we'll carry on with the tropical fevers then.
Thank you sir. So good evening dear friends, and regarding today's topic. So this is a time when after rains or during rains rather this time, and till the start of proper winters in North India, I would say till up to 15th of November, mostly 15th of mid-November. So this is the time when we see lots of patients coming to us with febrile illnesses. And out of those febrile illnesses, we typically have a very few limited illnesses which actually dominate in more than 90% of patients. say more than 95% of patients. What are those illnesses? And how do we approach a patient who is coming to us with a febrile condition? Patient is coming to us very in the very beginning days of our residency. We were taught about a very important thing. When you see a pregnant lady, and when you try to make a diagnosis in a pregnant lady, please don't forget she is a lady first, then she is pregnant. So same thing happens when somebody is coming with fever during this season. We know this is a season for a particular illness, maybe a more of a dengue cases, maybe more of a typhoid cases, more of a scrub cases, leptospirosis, but still patient can have a malignancy. Patient can have other chronic illnesses, underlying illnesses, which is now presenting as acute illness. Maybe something was going on. So please try to look at a patient as a whole. Don't jump to diagnosis straight away if patient is coming to us. So how do we, like, if patient is coming to us, how do we evaluate that patient, and how do we go with that patient of during this season? Fever coming during this season is like we say, if a duration of fever is less than 14 days, then we say it's acute tropical fever. So in a acute tropical fever, patient is coming. The first thing is first, somebody is coming to us, maybe in an OPD, maybe in emergency, anywhere. First thing is first history, observation, our observation, and listen to patient. Most important thing is patient is coming to us. 50 patients are sitting outside. Before patient starts speaking, we just write down, this is dengue, leave it. No, this may be something. Listen to patient. That is most important thing. Detailed history is very important. Please pay attention to what he says, what brought him to hospital. Try to find out diagnosis. As our sir and mentor always says, Dr. Sanjay Kala sir always says, patient is telling you diagnosis. Please listen to him. And that is the most important thing. Listen to him. And when we try to listen to patient, then he actually tells the diagnosis. If we are we just need to have that inner sense of sensing what he is telling us. Please pay attention to proper history, how many, from where he is coming. That is also very important. I'm living in Tri-City. If patient is coming from Upper Himachal, if patient is coming from close to UP areas, some areas in Haryana, then I will think of, if patient is having fever for 7 days, 8 days, 10 days, I have to think about scrub typhus. Patient is coming from Rajasthan, patient is coming from Gujarat and having fever with chills, I have to think about malaria. So geography is very, very important. From where the patient is coming. So these are very important thing in history. Now, type of fever, type what is a pattern of fever, character. So with chills, without chills, this can be sometimes be diagnostic, not always. Whether patient is having any underlying illness, is he having swollen joints? Is he suffering from rheumatoid arthritis in the past? He might not be, or she might not be taking steroids, might not be has taken any DMRDs in the past so many days. Sudden withdrawal may lead to this kind of exaggerated response, and acute febrile illness may not be infective at all. Very important history is whether patient has undergone a splenectomy in past. That will changes everything. We have to be very aggressive in managing those patients with febrile condition. So any history of exposure to animals, bites. So these kind of history, what I say is history is very, very important. And so more important is, again, very important is simultaneously look for signs. If we can see something, some rash is visible, his eyes are congested, throat is congested, then maybe like the patient is coming with a throat pain, we're just writing, please take a cetirizine tablet and paracetamol. We don't even bother to see, look into the throat. There may be a simple uh, uh, tonsillitis, follicular tonsillitis. Patient needs antibiotic. In all patients, in the majority of patients of throat pain and fever, patient may not need antibiotic. But please try to look into it. Anemia, jaundice. Patient is giving a clue that I am suffering from fever for last so many days. Now patient is looking pale, having icterus, and probably we're dealing with some sort of hemolysis because of fever, maybe a falciparum maybe scrub typhus, sometimes even in enteric. So please look, examine, give few minutes. few focused minutes. This will make our life easy, and for patients definitely make their life easy. So acute tropical fever. Well, this is like a plethora of conditions, but the most common conditions are viral fever. Among viral fevers, there can be dengue fever. This can be chikungunya. When comes like malaria in many parts of our country, in my part of country and my part of practice, malaria is extremely rare. We don't see malaria cases. Typhoid is very common. Scrub typhus is common. Leptospirosis again is very uncommon in my zone, but it's very common in Mumbai zone. Again, please don't forget, during this season, patient can again present with a bacterial sepsis. So it's not like patient will always present with any febrile patient is going to have a typhoid or malaria or scrub typhus or dengue fever. Can be actually in sepsis, bacterial sepsis. Might be having some focus, might be having liver abscess, might be having some other issues. So this is again very important. Then how do we approach? Patient is coming to us, is not giving time. We don't have this much of time to evaluate everything. There can be any number of reasons for fever. So how do we approach a patient? This patient is coming to us. So we have devised a syndromic approach to acute tropical fever. We can patient can divide the condition in 5 parts. This can be either acute undifferentiated fever, fever with rash and thrombocytopenia, fever with ARDS, febrile encephalopathy, or fever with multiple organ dysfunction syndrome. So one by one, acute undifferentiated febrile illness. This is a pretty common kind of diagnosis which we usually make in our setting. Patient is coming with a febrile condition of less than 2 weeks of duration, and there is no localization for fever. Patient is not having any localized reason to diagnose, like patient is having follicular tonsillitis or pneumonia or maybe some acute abdomen or any abscess, any other lesions which can tell this can be the focus. No focus, then probably we need to rule out either malaria, dengue, lepto, scrub typhus, typhoid, or other kind of viral illnesses. Acute undifferentiated febrile illness. Second syndromic approach is fever with rash and thrombocytopenia. Again, it's very common during the season. The first, foremost thing is to rule out dengue. Then is scrub typhus. Then is malaria, leptospirosis, measles, other form of viral illnesses, and meningococcal infection. Fever with ARDS. Patient is coming to us with either SpO2 is less than 90, or if we have a ABG facilities, then we can check PA to FI2 ratio less than 200. Then we are dealing with something more serious, maybe scrub typhus, maybe H1N1, maybe hantavirus infection, maybe falciparum-malaria. Melioidosis is not seen in my part, but in the south is pretty common. It's a chronic illness, but sometimes can present in an acute way. Patient was ignoring the chronic symptoms. He was having low-grade fever, but was ignoring somehow. Now presenting with the respiratory symptoms. Pneumonias and diffuse alveolar hemorrhage secondary to tropical fevers, the infections. This is also one of the rare diagnoses. Encephalopathies. Encephalopathies, again, most common is again viral encephalopathies. Patient coming with a fever, seizures, or ordered sensorium straight away. Then try to rule out other illnesses. Cerebral malaria in our Rajasthan part, Gujarat area, Bombay area. One have to be very, very careful. Are we dealing with some cerebral malaria? This can be typhoid encephalopathy as well. So have to be very specific, very, very particular, very cautious. We may need some neuroimaging and CSF. Fever with multiple organ dysfunction syndrome. This is multi-organ dysfunction syndrome is one thing which we all clinicians are afraid of when a patient is coming with febrile illness. Patient is coming walking maybe on with spot even, but very fulminantly turns into a multi-organ dysfunction syndrome. This can happen with any type of illnesses and during tropical fever. And we know this malaria, scrub typhus, leptospirosis, dengue fever they are very infamous for causing this kind of problem. Even hepatitis A and E, we have seen so many cases of hepatitis E causing FHF, fulminant hepatic failure this time. In the past, like 1 or 2 months, there are so many patients who are coming with hepatitis A and turning into a fulminant hepatic failure. Hemophagocytosis is a very dreaded complication of febrile illness sometimes. This is usually hemophagocytosis or macrophage activation syndrome, or HLH. Is like patient is coming to us with sepsis or some febrile illness, ultimately having a very rapidly developing pancytopenia, please try to look for HLH. HLH diagnosis is difficult and treatment is way more difficult, and prognosis is very, very poor. So, if you go to like, if we go by this kind of syndromic approach based on clinical signs symptoms, how a patient is presenting to us, probably this will make our life easy, and we should be able to reach at the diagnosis at the earliest and should be able to help patient. And tubular film, if you say a patient is having lymphadenopathy, one should rule out HIV. One should try to rule out other common like in acute phase, acute illnesses like acute tropical fever presenting with a lymphadenopathy is bit rare, except for like any kind of acute illness, maybe acute follicular tonsillitis can present with, or HIV can have acute presentation sometimes. So otherwise, they are more or less they are causes of chronic illnesses. Hepatosplenomegaly. This is pretty common, and hepatosplenomegaly is common in our like malaria, typhoid, amoebic or liver abscess. Uh, these patients do have this kind of hepatosplenomegaly, and one have a clue. And if patient is having massive splenomegaly, please rule out any hematological cause. That is also very important. Or chronic malaria patient is having. Jaundice, that is very important. One, please look into eyes. That is also very important. And try to find out if we are doing like in habit of doing only platelet PCV or CBC to begin with in a patient coming to us, and if we can find there is icterus, please look for liver function test and look for ultrasound maybe. So this can make us missing many important cases, treatable cases, and sometimes we have a florid hepatitis, maybe developing hepatitis. Patient is having acute febrile illness of 2 days, now having nausea, vomiting, and pain abdomen. State where this is dengue is going on all over. Please look into his eyes. If patient is telling his urine is very dark, please look for LFTs. Wheeze. Wheezing, we all know that like there can be so many reasons for wheezing. So this is how we can approach a patient with fever. Another very important entity is fever with rash. Fever with rash is like in during this time is during this season is typically please rule out dengue, typhoid, and leptospirosis, and maybe sepsis. These are the very important and very common reasons leading to fever with rash. So patient, like going on the same line, if you see a patient is coming with febrile illness, patient is having, we can see that now we have a labs in hand, we have some clinical examination, basic history with us. If patient is having liver and renal involvement, please try to immediately rule out malaria. That is very important. Please try to rule out scrub typhus, which is very common in our zone. Enteric fever, this can be one very important piece. So hepatitis A and E, please don't forget if there is a marked increase in SUTPD and along with jaundice. Patient with pulmonary involvement, again, complicated malaria, some type of viruses, Legionella, scrub typhus, any other type of sepsis can lead to this kind of involvement. Fever with rash, we have discussed. Fever with ARDS, against scrub typhus, leptospirosis, influenza, H1N1. Please don't forget, this is there, has not gone. Complicated malaria. Encephalopathy, mostly viral. This can be malaria, this can be typhoid encephalopathy, this can be scrub typhus. Again, a fever with MODS. So, patient, if we look at a patient, he's looking sick, he's looking ill, listen to him, try to listen to family members, what the history is, from where he's coming. That is the way we can really reach diagnosis very early. If we find that if we have a facility of ABC and we can find there is increase in lactate, there is definitely increase in PCV on, there is mild acidosis going on, probably we are dealing with impending dengue shock syndrome. These tests are actually very helpful. I wouldn't suggest ABC, will suggest VBG in these cases because arterial puncture in dengue with a very severe thrombocytopenia can be very dangerous. So in routine, we don't do it in a hospital. So this is a like how we can deal with, how we can approach a practical approach of patients. Now, very important thing is like we have seen this as a very common practice to order Vidal test in a patient who is coming, whosoever is coming with fever, please get a Vidal test done. And this is one test which actually irritates me as a clinician. Vidal is a test which checks the immunological response of that particular patient to a given antigen on that slide or in that serum, on that reagent. So, antibodies in salmonella infection develops in the second week of illness, not in the first day of illness. Please do not order Vidal test in the first week of illness. Please do not order typhi.igm in the first week of illness. These tests checks antibodies to these infections, and antibodies develop in the second week of illness. The test of choice for the first week of illness in typhoid, suspected typhoid, is always blood culture. So, in any case, a patient is coming to us during this season, please check malaria, dengue, CBC, and if need arises, maybe liver function, kidney function if need arises, then and definitely check blood culture. If patient is having dysuria, look for urine examination. Any patient who's coming to us during this season may have a routine type of infection which are not related to this season per se. Treatment is like depends what kind of fever we are looking at. Straight away, patient is coming to us and we are suspecting some sort of bacterial kind of thing. The very important kind of very life-saving kind of treatment is ceftriaxone with doxycycline. This has been proven beyond doubt. Please refrain from using carbapenems to start with in these patients unless until patient is in MODS and you're suspecting real sepsis. So this is a habit. This is what we are saying. Unfortunately, in our setting, patients are coming to us who has already received piperacillin as a victim. Patient has already received meropenem, imipenem. What was the reason? Fever of 1 day duration, fever of 2 days duration. Patient is coming walking. He was not in multiple organ dysfunction syndrome. So please, this has been proven beyond doubt in so many studies at PGI even, like ceftriaxone with doxycycline is the best empirical treatment during this season. And if we are suspecting dengue, we can wait for 1 or 2 hours. Fluid resuscitation is first thing that is to be done in all patients. And meanwhile, we will have some results which can suggest us what kind of infection we are dealing with. Are we dealing with dengue or not? In dengue, there is no role of antibiotic at all unless until there is a secondary infection going on. Patient is in MODS, on ventilator support, on dialysis, or maybe having underlying UTI along with. Otherwise, there is no role of antibiotic at all. Why I'm stressing on it? Because we have seen so many patients, so many patients coming to us. Whosoever is coming up with dengue is on antibiotic. Unfortunately, why? I don't know. There is no rationale of antibiotic. If you are suspecting, you are not very sure, you are having a resource limited setting, yes, some sort of maybe doxycycline. Sometimes you feel oral tablet is more than enough if patient is able to take it. If patient is not able to take it, obviously please admit. He needs fluid and workup immediately. So this was all from my side. As of now, nutrition is always important in even in a febrile patient also. Lots of fluid, and very basic thing is Nimbu Pani and Naril Pani. That is very important. And this was all from my side as of now. Thank you so much. And now I request Sanjay sir to take the charge again.
Thank you, Dr. Suneet. Wonderful talk. And like you said, you have to listen to the patient. If you listen, you get the answers. And then the second thing we learned from you was to go stepwise. Don't rush. So even in school, let's say you were trying to prove a theorem. What your teacher taught you was go through all the steps. And let us say you fumble at the last step. It doesn't matter. You'll still pass the exam. The trick is to follow all the steps. So that's what you've taught us. Thanks a lot for that. Many questions coming up for you. Dr. Vinay Desai asks, Sir, when do I suspect third space plasma leakage clinically? So, multiple questions. What is the third space? What is third space leakage or third space loss? The diagnosis and the treatment.
Sir, a very, very relevant and question as of now, because as of this season is going on, uh, the most important thing I would like to say as of now, before answering your question specifically, the most dangerous thing in dengue is third space leaking of plasma. It's not platelet count which is going down. So very, very important thing is, if we see there is an increase in hematocrit, very simple, very basic test to do is please check for hematocrit. This may be like, if you clinically ask me clinically what is the sign and symptoms, narrowing of pulse pressure. The difference between systolic and diastolic BP is very important thing. If you find, if I tell my residents very, very commonly, if you see a patient who is coming with a blood pressure of 120 by 100 and suspected dengue, 120 by 100 versus a patient who is coming with a 120 by 70, which one is sicker? 120 by 100 is very sick. He is losing he is losing fluid. He is having a low pulse pressure, and probably he is very soon is going into that dengue shock syndrome. Another, look for puffiness, look for any fluid leakage, clinical signs. If we can auscultate it, we can find out. Sometimes we have a basal effusion that we can actually auscultate and we can find out. If we have effusion, suspicion of effusion, if we have puffy eyes and very, very sick-looking patients, we are dealing with this kind of plasma leakage. But to check it early, but to find it early and diagnose early, which is extremely important in management of dengue to prevent them going into full-blown dengue shock syndrome, then we really have to check hematocrit along with platelet. So my humble request is, please keep checking hematocrit along with platelets. No platelet. If platelet is 5,000, 5,000, I'm not afraid of. If hematocrit is 60, I'm extremely concerned. Extremely concerned. Patient may die. 5,000 platelet, nothing will happen. There are so many patients, so many illnesses in which platelet count is low. If there is no ulcer, patient will not die. If patient is having already some ulcer and that bleeds, then definitely there can be issue. I'm not saying one should be very heroic with a platelet count of 5,000, but that is not very scary. What is scary is plasma leakage. What is scary is, which is suggested by increased hematocrit.
So the PCV and hematocrit are exactly the same, Dr. Sunit?
Yes, sir. Yes, sir.
So for those of us who are not used to using the word hematocrit, those of us from the older school of medicine, PCV is exactly the same.
Yes, sir.
The next question from Dr. Vinay was, how do we treat? Do we restrict fluids or do we increase fluids?
No, we give lots of fluid. We don't restrict. Simultaneously, we need to look into, like, if patient is having massive pleural effusion, then we have to be very, very cautious. But we cannot restrict fluid to begin with. Initial hydration is very important, and followed by we have, like then you have to be cautious depending on patient situation. If patient is going into respiratory distress because of that fluid, definitely we have to restrict.
The fluids, can we give oral fluids with glucose and electrolytes? Should we give intravenous? Between crystalloids and colloids, how do we choose?
Sir, it's always crystalloid to begin with, no confusion in there. But yes, we can use colloids also. But the very important thing is crystalloids, simple normal saline is very, very important, and that is to be given to begin with. And oral, regarding oral therapy, yes, if patient is able to take it, keep on giving him oral, no issues. But if you are
Don't
afraid of patient is sick, patient is vomiting continuously, then there is no point in giving oral.
Many more questions still to be answered. And Dr. Rajkishore Maheshwari has a very important question. Sir, in your practice, in your experience, in what percentage of patients is clinical diagnosis alone sufficient? And in what percent are the investigations mandatory? For those of us in primary practice, can you give us a pragmatic tool, when to begin investigating? Because patients sometimes are not very keen to get their test done.
Sir, in the case of tropical fever, I'll suggest to go with in some investigations. That is very, very important today's era, at least, when we have like medical legal cases uh, always waiting for us. So there is patients, if some zone is there, say there is a town where is we know that cholera is there. So every gastroenteritis is probably he's having cholera. We may not be interested in proving this is amoebic or cholera or maybe some other infection. We can treat them empirically if patients are coming. So many patients are coming from clusters are coming from that particular area. But in today's era, sir, even in those patients, you have to monitor something. You have to monitor renal function, electrolytes, everything. Then ultimately, you will need some sort of blood test. In PHC, if you're setting a patient is coming to you with a febrile illness, again in dengue patient can present with a very mild illness. Patient may not have a very high grade fever, very mild illness, and ultimately on a day 3 or day 4 may straight away go to emergency. Patient may not come by himself on the second or third or fourth day. So it's wise to get the lab done in almost every patient who is coming with febrile condition during this period. So in what my practice is, during after November, after mid of November or maybe December, practically for febrile illnesses, especially sore throat, normal febrile illness, patient is coming to us, maybe we don't do any test. But the patients who are coming within the mid of July till mid of November, we do a test in all each and every patient who is coming to my OPD. Even if only CBC is more than sufficient, we can get so many inferences from that CBC. If patient is not able to afford, at least get CBC done.
So the point is that these investigations are required, first of all, to clinch the etiology, the diagnosis. Secondly, to look for comorbid conditions and complications. What is happening to the liver, to the kidney, to the heart. Third, it's for risk stratification. Should I keep the patient with me? Should I refer to a level above me, tertiary, super tertiary level? And fourth is to keep an eye on the natural trajectory or the clinical history. Like for example, some diseases are monophasic, maybe infective hepatitis. Others are multiphasic. You can have fever in dengue, and then the patient can, become stable. But that is the lull before the storm. The patient can worsen after 10 days or so. So that's a biphasic. Others can be polyphasic illnesses, maybe an autoimmune disease. So just to find out what kind of a natural history there is, for that also regular investigations are required. One question I'll take, Dr. Vinay asks about imeglimin. This is neither a gliptin nor a sulfonylurea. This is a glimin. It is a new class of drugs. It is the beauty is it is an insulin sensitizer as well as secretagogue. So you take it as a mild kind of a sulfonylurea and as a mild kind of a metformin put together. Very mild. Some people respond like magic. Others don't respond at all. The insulin dose does come down in most patients where we use it. So 500 milligram BD, and then you can go up to 1000 BD. Dr. Vinay, you can use it very safely in patients with renal disease. Even if the AGFR is 15-20, you can still give 500 milligram OD. Dr. Sunit, this question from Dr. Bhupinder Singh, as well as from Dr. Vinay Desai. Scrub typhus you mentioned at the beginning of your talk. So what are the pathognomic symptoms and signs? How do we test? Why is the testing difficult? And once we've confirmed the diagnosis, how do we treat?
Sir, during this season, if patient is coming with febrile illness and we have ruled out malaria and dengue, that is very, very important because these tests can be done within the first day of illness of presentation. Regarding this NS1 antigen test, this can be done after 6 hours of onset of fever. This can check it. This can detect it. And if you suspect very strongly and first test is negative, you can repeat on the second day. Second is I'm talking about dengue, not scrub as of now. Then is very important test is again card test for malaria. That is also very, very effective, very, very sensitive, and we can rule it out whether a patient is suffering from malaria or not. After ruling these two out, we start a treatment which covers scrub typhus empirically. So we give patients ceftriaxone and doxycycline because scrub typhus is tested with the antibody response, and that too after first week of illness. So there is no rationale of waiting for 7 days. Meanwhile, again same holds true for the typhoid also. Typhoid you cannot diagnose on a first week or first day or first in the first 2, 3, 4, 5 days. One can have some pattern. If patient is letting his fever go up, one can find out a step ladder pattern. Very basic question I do ask to my patients, to every patient who is coming with a fever illness, maybe after 3 days or 4 days, I do ask, what was the fever worst on the day one, or it's worsening now? If patient says it was worse on the day one, probably we are not dealing with scrub typhus or leptospirosis. This is either a viral illness or some other kind of illness. Maybe dengue. This is possible. Maybe malaria, something else. Typically, this scrub typhus, leptospirosis, and enteric fever, typhoid, they do worsen as the days goes on. So this is like one clinical clue towards these kind of illnesses. There is no rationale of waiting for a diagnosis of scrub typhus to be established, which will be established after at least after 7 days of illness. So what we practically do is give them ceftriaxone, 100 milligram per kg per day. We give them doxycycline daily. If patient is able to take orally, oral doxycycline, not IV doxycycline, and after 7 days, if need arises, patient is having hepatic dysfunction, patient is having renal dysfunction, then we strongly suspect patient is having splenomegaly now. Then we strongly suspect the patient may have this scrub typhus. Patient is coming from that endemic zone also. So to establish or to label that patient as a correct diagnosis, we go for a scrub typhus IgM. I'm sitting in a tertiary care center. Patient who come on a day 7, day 8, day 9, day 10. I don't suspect dengue on a day 8, day 9, day 10. I don't suspect malaria on day 8, day 9, day 10. But if there is a change in pattern, patient was having 100-degree fever, now having 104, then this raises the bells. Because probably he was suffering from something else to begin with. Now he might have a malaria or dengue. Then we check. Otherwise, we don't check malaria or dengue on a day 7, day 8, day 9, day 10. So then we look for, then on a seventh day, we definitely send, or eighth day, if patient is coming to us on those days, scrub typhus IgM by ELISA, which is for specific and sensitive testing. So this is how we diagnose scrub typhus and how we deal with it.
Now, you used the words ceftriaxone and doxycycline together. And traditionally, we were taught that bacteriostatic antibiotics should not be combined with bactericidal. But we see this change quite frequently now, while you are managing enteric fever, while you're managing atypical fevers. Also in diabetic foot, linezolid, for example, is bacteriostatic, but that is combined with bactericidal. Is this change common across various fields of internal medicine, or is it limited to just these two or three examples?
Sir, probably there is a difference in a pharmacy lab and a clinical scenario. We have not, because this question rises in my mind multiple number of times whenever I prescribe linezolid specifically and doxycycline many times, but especially linezolid. But still, we have not seen anything like patient is not responding, patient has responded poorly. Clinically, there is no response. But classical teaching was, please do not combine bactericidal with bacteriostatic. We have not seen any like clinical relevance of the same theory.
We should also remember that sometimes there is a multimicrobial infection. So, why two antibiotics are given is because you think there is more than one etiology. So, usually that is the reason. You want to give different antibiotics to cover different bacteria. So, the bacteriostatic drug is acting upon a separate bacterium, and the bactericidal one on a separate bacterium. That is also one logic for the diabetic foot management when such a combination is given. More questions are from Dr. Suresh Shukla. Chikungunya with arthralgia in persons with diabetes. What is the role of HYQ and any other drug that you prefer?
Sir, difficult question and difficult answers. I don't have any straightforward answer for this. Patient is coming with like severe debilitating pain. Chikungunya test may or may not come positive. And even then, we know this is chikungunya kind of illness, chikungunya-like illness. Patient have a very severe debilitating pain. Even they do not respond to routine NSAIDs. And then in many of patients, especially after first week of their suffering, we use HCQS. So hydroxychloroquine is used, and we keep it short usually, maybe for 3 weeks, 2 weeks, 3 weeks, and then look for a response. In many of these patients, one may have to use a short course treatment with the steroids even. They have such a severe pain, such a severe swelling, pain, inflammation going on, and then they don't respond to HCQS. We all know that this is slow acting molecule. This is not going to act within like 7 days. No, this is not going to work. So in those patients, 5 days therapy with methylprednisolone or maybe bisolone in a lower dose is very, very effective sometimes. Some patients, almost 10 to 15%, 20% patients continue to have this kind of arthropathy even after 3 weeks. And these patients require some treatment and further evaluation. In some patients, we can find out that this chikungunya episode or this viral illness episode has unmasked the underlying
Autoimmune
rheumatoid
disease.
arthritis,
Yeah.
autoimmune disease.
It can act as a trigger. And the specific question for persons with diabetes, HYQ is approved for treatment in type 2 diabetes as well. But do try to keep the duration as short as possible. And secondly, in case you have to give a steroid, do not hesitate. Even if the person has diabetes, do look for post-lunch glucose, pre-dinner glucose. If you have put your patient on prednisolone or methylprednisolone, the highest glucose peaks will be after lunch up till before dinner. So do add some kind of a tablet, a short-acting sulfonylurea, a repaglinide, maybe acarbose with lunch. Dr. Dawood Khan asks, dengue positive patients with thrombocytopenia. You already mentioned we shouldn't focus too much upon the platelet count, but can you give us the thresholds? Uh, Platelet count threshold. At what threshold should I begin counseling my patient? So that's a counseling
Thank
threshold.
you so much for asking this question, sir.
So multiple thresholds. That's Dr. Khan for you.
Thank you so much for
Okay,
asking
Dr.
this
Khan.
one because I would have forgotten telling this question. This is my favorite thing, and would like to tell. Sir, what I tell practically when we were at PGI, we used to tell unless until platelet count falls below 10,000, please don't come to us. So that is not a practical approach. And what we practically say is if platelet count is less than 30,000, and please do come to hospital. You may need in hospital care. That give us two things. If patient is walking, eating very nicely, and rate of fall of platelet is not very low. His platelet count was 32,000, now it's at 28,000. And next, you do in the OPD, then it turns out to be like 27,000. We don't admit. There is no need to admit. And if you see that platelet and this PCV is stable, PCV is not high, PCV is in the range. To me, a range of PCB, to everyone, the range of PCB is less than 50, but to me, the range of PCB is definitely less than 50. If patient is crossing 50, then I'm little concerned. If we have a values from if we have CBCs, before he was L, his baseline PCB is 51, 52. He's from the far, like north areas, from Ladakh. So his PCB may be high. Unlike if his baseline PCB was high, then I have to concern. Like if unless until there is a more than 25% increase in PCB, I'm not concerned. If patient is telling me his platelet count is 35,000, and please go and sleep at home. If patient is coming to my OPD and saying this platelet count is less than 30,000, let me check it. Let me confirm it. Let me confirm with the manual count. Is it really this much of thrombocytopenia? Are you having any other issues? Is there any derangement of hepatic functions? Is there any abdominal tenderness? Any other warning red flag signs in dengue? What are red flag signs in dengue? Upper abdominal pain, excessive vomiting, and patient is having hypotension, that is extremely serious, and having cold sweats without fever, that is extremely serious. Patient has unexplained ghabrat. Patient is not psychogenic. He's having extreme ghabrat, not because of lack of platelet. He is very uneasy. Please admit, even if patient is having platelet count of 1 lakh. Please don't go for platelet count. If you ask me specifically what is a platelet count, when you start admitting, I start thinking when platelet count fall below 30,000. That is actually too much from the PGA standards, but where I was taught. There is must to admit patient when platelet count is less than 20,000 as per book. Less than
So
20,000.
20, yeah. So 20 to 30,000 would be a rough threshold. And of course, we shouldn't go by a single number. You have to look at the clinical situation, the patient's concern, and also you have to look at the PCV or the hematocrit along with it. Would there be scope, Dr. Suneet, for doing research on a PPP, PCV platelet count product, or a ratio, the higher the PCV and the lower the platelet count, if you take them together? Would we be able to create an algorithm which would help us define whom to admit and whom not to.
Sir, maybe I have not given any thought about it regarding this ratio particularly, but yes,
Yeah, it
anybody
should
who
be a
says
ratio, not a product. Yeah, it should be a
no,
ratio.
I have not given
It's
any thought. But the if patient is having rising PCV, I'm very much concerned. If PCV is in control, even if patient is having a 10,000 platelet, we don't transfuse. Patient is not running fever, and patient
Doctor.
is understanding. He is able to understand. We don't transfuse.
So
And
one is the
regarding
threshold for the platelet count, Dr. Sunil. The other would be the threshold of days. After what day of fever can you feel that now the worst is over and now we don't need to worry, we don't need to do too much of repeat testing for platelet count? This is
worst,
from a dengue
worst,
point of view.
worst period is 3 to 7 day, third day to seventh day. That is
So
the worst period.
yeah, that will also influence our threshold, Dr. Dawood. If it's between day 3 and 7, we are more vigilant. Platelet count coming down from 40 to 30,000, we will be more proactive. But on day 8, day 9, we can lower our guard slightly, at least when it comes to looking at the thrombocytopenia. Dr. Sunit, still many more questions left. And Dr. A.H. Zen says, could you please repeat slowly? What is the diagnostic test for typhoid? What is the diagnostic test for scrub typhoid? In one sentence each, please.
Sir, diagnostic test for typhoid is blood culture in the first week of illness. In the second week of illness, eighth day onwards, the test is either Vidal done by a tube method, not by slide method, or Typhi.IgM. Typhi.IgM and Vidal do have a limitation. They are not 100% sensitive and definitely not specific. They can miss, they can be falsely positive, they can be falsely negative. The gold standard test for typhoid is blood culture in the first week of illness. The standard test for scrub typhus
Scrub.
is IgM by ELISA method. IgM antibodies in the second week of illness by ELISA method.
IgM
IgM.
by ELISA
IgM
after day 7.
after day 7.
So you can't diagnose within the first 7 days.
No,
There's no blood culture for scrub typhoid.
no, sir.
Dr. Amit Suyal says azithromycin is a drug that is used and misused quite frequently. It has its advantages, but that doesn't mean it's a panacea for everything. What is the role of azithromycin in tropical fever?
Excellent question, sir. When I said that in a patient with undifferentiated tropical fever, this term is very, very, very nice, and we learned this from Dr. Ashish Bhalla and Vijay. So, undifferentiated tropical fever, acute tropical fever, start with ceftriaxone and doxycycline because we don't have a diagnosis of typhoid, we don't have a diagnosis of typhus. Start with it, and then modify your treatment in the next 24 to 48 hours according to the best possible diagnosis you could make. If you strongly suspect this is enteric fever, I would like to use azithromycin in place of doxycycline in 500 milligram twice daily dose for 5 days rather than doxycycline, and will like to continue with ceftriaxone. If we suspect, and then we have like more of a scrub typhus kind of a clinical scenario going on, I'll continue with ceftriaxone and doxycycline. This is how we practically do.
Dr. Mahendra Sharma has a query. Can Vidal test become negative in a person who previously had a positive Vidal in the short term?
Sir, Vidal test, how you do Vidal test is very, very important. And this is one of the most annoying report in OPDs. Everyone is coming with, I have a typhoid. Okay. Since how long? 2 years. I'm having typhoid for last 2 years. Okay, fine. Do you have fever? No, I don't have fever, but I have typhoid. So typhoid is like, I don't know who has told our
Population.
population that this is typhoid. I don't know what is typhoid. Typhoid is fever. Please try to understand this. Typhoid is not nothing. There is no typhoid. It's a typhoid fever. So if there is no fever, there is no typhoid, please. And if there is a particular pattern, there cannot be typhoid for like 6 months. There cannot be typhoid for 2 years, 3 years. And patients are getting repeated Vidal test and taking ofloxacin or maybe ciprofloxacin with the cefixime course, 15 days, 20 days, 1 month, and after 10 days, again they repeat and then take this tablet because their Vidal test comes repeatedly positive and they keep on taking it. The question was, if can Vidal test be negative? Vidal test can be falsely negative, sir. But Vidal test is an immunological response. This tests are immunological response, IgM antibodies. or IgG antibodies. Patient after suffering from typhoid or after vaccination, they develop antibodies. Antibody development and antibodies persistence varies from person to person. So definitely this test can be pseudo negative or maybe truly negative after some time.
I'd like, Dr. Mahendra, I'd like to share a simple counseling strategy. Whenever a patient comes to you and your first answer is no, the patient steps back. So I would like to request Dr. Sharma, please don't be annoyed. Don't get frustrated. The first A is accept. So, yes, you have a positive report. Acknowledge. I understand that you went to the lab because you are worried about your health. And I understand that the laboratory personnel has done his or her best in doing the test. So accept and acknowledge. But then you change gears and then you appreciate. See, you have a positive typhoid report. Now, that is not a wrong sentence. But still, because of your innate immunity, you've been able to fight it. There is always a chance of you having typhoid. And in Hindi, you might want to use the word Hanji, typhoid abhi हड्डियों में बैठा हुआ है, typhoid का कीटाणु है, typhoid को response आ रहा है, whatever sentence you may wish to use. So it's yes, I appreciate what you've done for yourself. The credit goes to your immunity, your innate immunity, and all the calcium and vitamin D you've been taking, and all the treatment you took from Dr. Sharma and Dr. Sunit, that you've been able to come out of it unscathed. There is no negative influence on your body because of this positive report. But that is up till now. Now, what do we do for the future? We'll give you such and such medicine, which can be a B complex, it can be Enerzel, it can be Neurobion, it can be calcium vitamin D, or whatever else you want to give. You might want to say, as long as you keep your glucose and other metabolic parameters normal, the typhoid report is not going to trouble you. That is also a correct statement. It is scientifically proven. Uh, However, for follow-up, if the patient is very concerned, then you say there is a better test than this, and maybe we can do a CRP. Maybe we can do a simple TLC, DLC. If these are normal, what it means is that you are in charge of the typhoid. The typhoid is not going to defeat you. So you just change your counseling strategy, and then you will find that your patients will be more accepting. Also, if you happen to be in private practice, do not unnecessarily criticize the person who did the Vidal. He did it in good faith. And even if he had not done it, the patient would have gone to another lab to get the typhoid test done. That is ingrained in psychology and in sociology. So you just change the test, and maybe the next time the patient will come back with a CRP or ESR, and then that is another story for another counseling strategy. But Dr. Sunit, still many questions coming up, and it is nearly 10 p.m. One question coming up from Dr. Sanjay is, do you spend so much time in counseling all your patients in the OPD and ward?
This is true, sir. Yes, definitely. It's not like saying over here, yes, definitely, I do. When I diagnose or suspect dengue, this is like a lecture, and my juniors used to say that please make a recording and give it to everyone they can listen to. But no, I would like to tell them what is dengue and what do we expect, what do you expect from me. This to
So
happen.
actually, this is to everyone who's listening. Actually, Dr. Sunit does walk the talk, and he actually does that, and his counseling skills are super excellent. A question from Dr. Shihora: is nimesulide safe as an antipyretic for tropical fever?
Nice question, sir. Thank you so much for asking this again. No NSAID is safe. No NSAID is safe during tropical fever unless until we have ruled out fever causing thrombocytopenias. If patient is having a thrombocytopenia, please don't use NSAID. They cause platelet dysfunction. So bestest thing is like please avoid NSAID unless until it's an absolute necessity. Regarding particular nimesulide, yes, nimesulide is now coming up again with the theories that it is safe. It was not that unsafe, which was like previous theories were saying. So I'm not saying any nimesulide or aceclofenac or maybe ibuprofen. I'm saying any NSAID. Please avoid any NSAID. Only PCM is the answer.
Yeah. Though Dr. Sanjay, I do use nimesulide myself, but not in a regular dosage, but as a stat or as an SOS dose, sublingual, when you want the fever to come down and when the patient is feeling uncomfortable because of the high fever. But it's an SOS prescription, never a twice daily or thrice daily kind of prescription. Dr. Tarajjot Singh continues with this discussion. My patient has got allergy to paracetamol. Then what do I do?
If patient is suspecting dengue, I would not like to use it. I would like to do cold sponging.
And another question for sponging, which we had kept. This is from Dr. Gangadhar Rath from Karnataka. He says sponging is fine, but there is a controversy. It is said that ice cold, the term he uses is ice cold water, will produce vasoconstriction, shivering, and may raise temperature. Warm water sponging will cause vasodilatation. So, what is the right practice? And does it vary if the temperature is up till 101, 102 degrees? And if the patient has hyperthermia, will our approach vary in such cases?
When we do cold sponging, the word is cold sponging. This should be colder than your body temperature. Then this is cold sponging. There is no need to warm it. Best strategy is a normal tap water during summer season. During winters, make it lukewarm and then do it. Never ice cold, sir. Ice cold is not recommended. Was never recommended. So, aim is to wet your body and let heat evaporate. We are not doing direct cooling. What you are doing is you are just making your patient wet, and then uh, keeping the fan on and letting the heat evaporate, and that is the best strategy. Many a times, and most of the times, patient do not tolerate fan. It's okay. Just just make him wet and remove the towel from the body. And this is also seen. Patient are keeping towels on the body. This is not cold sponging.
And heat stroke would be a separate topic that we will request Dr. Sunil to talk to us about later during a later episode. Question from diabetes. Dr. Anand Purandare shares the case of a 20 of a young lady, primi gravida, 8th month of pregnancy. Her fasting glucose is 108. OGTT highest value is 192. HbA1c is 5.4. Weight is 59 kg. Do we need to give insulin at 108 and 192 fasting and post glucose along with A1C 5.4, or can we manage with MNT with medical nutrition therapy?
So 192 is too high. I think it should be managed with the short-acting insulin at least. Whether I would not suggest any long-acting insulin straight away. Maybe when patient is having a blood sugar level of more than 140 post-pregnant sugar, we can manage in this particular patient, and maybe short-acting insulin is going to be helpful. MNT should continue, and then keep on monitoring sugar levels.
It will depend upon the previous diet also, Dr. Anand. So it's the 8th month. Now about 4 to 6 weeks are left. If the patient says she has been binging on sweets and what we have here in the north is ghevar and panjiri and firni. If she's been binging on that, then let her stop and check the glucose again after 2 or 3 days. But don't call her back after 2 weeks, 4 weeks. It has to be a daily, twice weekly kind of a follow-up. And if glucose levels are still high, then we think of insulin. Also look at the health of the fetus. If there is the slightest evidence of fetal distress or maternal distress, start insulin immediately. If there is ketonuria, not even ketosis or ketoacidosis, just ketonuria, then also don't take a risk, start insulin. Dr. Gajanand Sanab says 50,000 platelets. So the threshold theory, there can be no single number because this says with 50,000, now my patient is come with black stools. Black stools can be because of a multitude of reasons. But what do I do in such a case?
Admit. First of all, if this is a black hard stool, there is no need to panic. Patient was having constipation, maybe was taking iron. There is no rationale. Patient is having liquid black stool, black tarry stool. Definitely need to admit. Reason is not thrombocytopenia. Reason is black stool. Patient is having GI bleed probably. Please rule out GI bleed. That is the most important thing. Even if a patient's platelet count is 1.5 lakh or maybe 2.5 lakh or 3.5 lakh or 4 lakhs, patient is having black stool, please admit. Second is regarding the threshold for transfusion. Any bleeding when platelet count is less than 75,000, please transfuse SDA. Any bleeding.
So the earlier number that we said 30,000, that is not to be taken in isolation. You have to look at the clinical situation, and that would be a strong message, right, Dr. Sunit?
Yes. Anything that is very, very important, and any bleeding, patient is bleeding actively, so then threshold for platelet transfusion is anything less than 75,000. There is nothing like 30,000, 20,000, 10,000, 5,000. Nothing.
Symptoms and signs come first. The laboratory comes next. That rule we should remember in clinical medicine. Good evening to you from Dr. Jenny Ortega, one of our regular listeners. And Dr. Bhupinder Singh repeats a question that you just discussed. Most patients don't respond to paracetamol. We also do sponging in the right manner, ensuring that we use the right temperature of water over a reasonably adequate surface area. And then there is a pressure on us to use NSAIDs. So, how do we navigate this?
Counseling, counseling, counseling. That's it.
uh, Another counseling strategy would be that fever is good. So if you just cheer up the patient and say the fever is there, that means you are fighting the illness, you are fighting the bacteria, and this is a sign that you are going to win. That makes the patient, a bit more, what do I say, a bit more confident, a bit more trusting, and then you are able to manage until your next round at least. So you use positive aspects of the fever. See, with the Dr. Suneet, we spoke of the Ishq ka Bukhar, and then there are other things also to speak about, various etiologies. So it depends upon the gender and the age of the patient you are counseling, Dr. Bhupinder Singh. This might be something you may wish to try tomorrow in the OPD or in the ward. Don't try it on the wrong gender, and don't try it in certain age groups, people who are elder to you. Otherwise, at least in Haryana, you get in trouble. Dr. Nitin Narula, for the last 2.5 years, I've been telling you which is the best and safest gift. In Nitin, अब तो कुछ और उस पे आ जाओ, देखो hemoglobin पूछ लो, कुछ और पूछ लो, कोई नई दवाई पूछ लो. And today आज का टॉपिक है हमारा जिस्मानी बुखार. तो नितिन उस पे सवाल पूछो ना जिस्मानी बुखार पे. So Dr. Suneet is there to answer. Okay. And mind body integration yoga, Dr. Ramesh Kumar says anamnestic reaction in Vidal. This is what Dr. Suneet discussed and we discussed. Okay. वो it's an immune response, but actually there is no active or live typhoid bacterium in the body anymore. So that's what amnestic reaction means. It will stay for many months. Dr. Bhupinder Singh says wheel Felix test in scrub typhus. Is it still relevant?
We practically don't do it, sir. So wheel
It's one
Felix
of
has
the
so
older
many
tests.
positive pseudo-negative reports, so we don't do it.
Pertinent questions, couple more from Dr. Shazana Haider Ali. Madam says the exact dose of ceftriaxone and the exact dose of doxycycline, please, for strep typhus, and the duration as well.
But we practically do adult is coming to us, not pediatrics. Obviously, I'm not dealing pediatrics. So adult is 2 gram twice daily and sometimes 2 grams thrice daily because it's 100 milligram per kg per day IV dose for ceftriaxone. It's a 5 milligram per kg per day for doxycycline. So usually 100 milligram BD.
Let's repeat that slowly. Doxycycline is
Is
100 milligram BD, oral for how many days?
For 7 days, sir.
7 days, and there is an intramuscular preparation available as well.
No, sir.
Or
There is an IV
intravenous.
preparation and there is
IV
intravenous.
preparation is available.
Intravenous. We are using a lot.
The dose will be the same,
Same. It's the same.
100
One
BD.
have to be very cautious while giving doxycycline if patient is having a florid hepatic dysfunction. I will not say jaundice. Jaundice is something different. Is having hepatic failure, FHF, fulminant hepatic failure, or impending fulminant hepatic failure, where there is a problem with coagulation. INR is getting deranged, or his OTPT are getting very high. Normally, the reading is more than 2000, 3000. Then, and they are daily increasing. Please do not use doxy. This is one of the hepatotoxins.
Ceftriaxone, let's repeat slowly. The dose is roughly 2 grams to 3 grams intravenous per day.
2 grams BD.
BD. So roughly 4 grams per day given in 2 divided doses intravenous. Dr. Manisha Sharma says tropical fever, viral probably, with very high ferritin level. So she has multiple questions. What does a high ferritin mean to us? And low WBC and low platelets. We've talked about platelets already. So her second question is, what does low WBC indicate?
Nothing. It's a simple viral infection or maybe atypical infections and showing some sort of bone marrow depression. That's it. It has no relevance in the recovery. There is nothing like we need to increase WBC count artificially by giving some sort of GMCSF or GCSF. There is no rationale. This will recover. And second one, sir?
Ferritin.
Ferritin is an acute phase reactant. Any illness can lead to increase in ferritin level. Any febrile illness can lead to, and specifically we have seen that in COVID. So there are few illnesses which can lead to increase in ferritin level. There are so many reasons, but to be very like on a serious note, I would suggest one thing to be very watchful. Patient is with you, is going into multiple organ dysfunction. Patient is with you for quite some time, and he's on multiple antibiotics. He's in sepsis, and now he's having thrombocytopenia, anemia, and leukopenia, along with very high levels of ferritin. Please be wary of HLH, hemophagocytosis. This can be extremely important and early marker of impending HLH. Please do bone marrow examination, find out macrophage activation syndrome, and treat accordingly. And that is usually treated in tertiary care centers and with extremely high mortality. Treatment is normally steroids are failed, immunoglobulin failed, IVIG failed, some sort of chemotherapy, etoposide kind of therapies sometimes do have some sort of success. Sometimes secondary HLH, there is no term like secondary HLH nowadays, but they do respond to treatment of sepsis per se. But HLH is like one of the markers, like ferritin, raised ferritin can be in a very severe patient. I don't know in what context Dr. Sab is asking. If she's asking in that context, probably please rule out HLH.
Actually, Daksab's question was quite straightforward, and you answered that. How can we treat a typical viral fever? So what you have mentioned is that the low WBC, low platelet, that will be part of the typical viral fever, and you treat symptomatically. And the high ferritin you mentioned, if it's very high, then that is a poor prognosis. So you may wish to refer to a higher center. One question, Dr. Suneet, if you can take from cardiology. This is from Love Humanity. On echo, patient has severe MR, mitral regurgitation, but patient is asymptomatic as of now. Patient had acute coronary syndrome earlier, and the standard treatment is going on for acute coronary syndrome. So the question is, should I repeat an echo? Because there is discordance between the symptoms and the echo finding. Echo is MR, severe MR. Secondly, should I add a diuretic because the echo also shows a dilated atrium?
So both things are very important. As far as I know, cardiology I am not, but still, but I practically, if I was in like your place, what I do is definitely will add diuretics, no confusion, and will like to rule out repeat echo from a reliable source. If there is MR, probably that MI has led to papillary muscle dysfunction, and there is a rupture of papillary muscle. This may lead to, if this is an acute MR, may need an urgent surgery. Patient will be well off for life. If we don't do surgery at this point of time, and the patient will be on like symptomatic throughout his life. So what I suggest is, like, if you document there was MI and there is an acute MR, please refer to CTTs.
Point well taken, and I have also learned something new. This will be an indication for cardiothoracic surgical intervention. Of course, the surgical indications are going down as medicine is improving. Thank you from Dr. Bhupinder Singh for answering all the questions so patiently. And Dr. Nitin asks, any safe antibiotic on the stomach, any antibiotic which does not cause loose motions?
There are so many such. Cefixime per se doesn't cause. If you need to use cefixime, I do use cefixime a lot because of this reason. There is no nausea, there is no loose motions. It's very nice.
The antibiotic should be chosen according to the etiology, Dr. Nitin, according to the cause. So let us say patient has got a fluctuant abscess, then we have to give metronidazole. If the patient has got a urinary tract infection, then you have to give a treatment for urinary tract infection. If the patient has got a sore throat, then the treatment is for sore throat. Sexually transmitted disease, the treatment will be for that. And there are syndromic ways of approaching this, of approaching STD, for example. But you should know the etiology. You should know what you are fighting before you choose the weapon. Still more questions. We'll take a few minutes more of Dr. Suneet. It's 10 past 10 already. Okay, the maximum dose of ceftriaxone, Dr. Vinny is asking, per day.
So what we practically use is 4 grams a day, and what many of my colleagues have used in PJ is 6 grams a day. So book writes 100 milligram per kg per day. So practically they are not wrong in saying so, but there is no place where we could find a higher cutoff limit. This is a cutoff limit for maximum. This is a maximum dose of ceftriaxone. So do
Dr.
practically
Vinny, another question, test for leptospirosis. What test do we do in the first week or beyond that? There is a high index of clinical suspicion.
IgM antibodies, again, in the second week, not in the first week. There is no test in the first week.
No test for the first week?
So probably there is some antigen because we are not getting cases of leptospirosis, so I'm not aware of. Maybe some antigen test is also available for leptospirosis. If that is
We can
available,
get
then we can run the first test, first week.
We'll get back to you next week, Dr. Vinay. Thanks for asking this, and we'll remember to take this question up next week. Dr. Jaideep Mankani says a very warm hi to you. And how do I treat extensive stomatitis with fever and leukopenia?
This is one of the difficult issue because stomatitis is remains like one of the most irritating problem for patient as well as physician. And what I practically do is some sort of local applicants and along with probiotics. And if patient is able to take curd, that is also very very beneficial. Avoid any type of harsh drinks or food, hot food, spicy food. So this gives them a soothing effect and they heals very quickly.
Probiotics really help a lot, and so does curd. You can tell the patient to take 100 grams 3 4 times a day. Another folk therapy would be licorice. The Hindi word is mulatti, and many people respond to that. And when would you want to use an oral steroid oral paste? Would that be indicated in some patients?
Very rarely, sir, patient is not responding, having a very severe kind of. Then we have now available. The pharmacological products are available. I won't say the brand name as of now. They are available. We use them.
We'll take three more questions if everybody allows, including Dr. Suneet. Short
Sure.
answers, please. But thank you, everyone. We did know that this is an important problem. It's a burning problem, this tropical fever. But honestly, I never realized that there would be so many questions. And we'll be handing over to Mr. Basu in a few minutes. I'm sure he also didn't realize that. But we are happy that we got Dr. Sneeth on board today. Thanks, Dr. Sneeth, for joining us, even though you did not share your personal experience in the beginning. Dr. Dhananshri Patil says, patient with low platelet count, dengue is negative. I've done the test. What is the next investigation or the next treatment I should do? Just 1, 2, 3, order wise.
So
Fever is
depends on
not. Yeah.
depends on the clinical profile. How many days of fever is there? If even if the dengue is negative, patient can have dengue. Almost 97% of patients are picked up on dengue test. 3% we missed out because there is another strain of dengue going on for which we don't have developed any sort of test in India. So we can still miss a 3% cases of dengue with actual dengue and the patient behaving like dengue. Please treat them as a dengue. If patient test is negative, if patient is running fever, we suspect dengue, please add antibiotic. Please add ceftriaxone, please add doxycycline, and then see how it behaves. This too happens with us. I'm sitting in a tertiary care, so we do get these kind of cases very regularly. Patient's dengue test is negative, even if you go for an ELISA test, which is more sensitive and more specific as compared to this CAR test, still we have a missed patients of dengue. Typically behaves like dengue, typical transaminitis, typical pattern of 3 to 5 days of fever followed by, along with a decrease in platelet and increase in PCV count, and followed by there is a subsidence of fever, improvement in hepatic functions, and ultimately patient gets well. But what we practically do is patient is running fever, and even if we suspect dengue and dengue test is negative the 2 times, when we add antibiotics, there may be something underlying going on. Please try to rule out other causes of sepsis. Maybe having underlying UTI, maybe having underlying abscess. Please rule out liver abscess. That is also pretty common and often missed, even if ultrasound is not done properly. This can be missed. And rarely, yes, we can find out SABE, subacute bacterial endocarditis. This can be also be one of the very important reason of PUO, which we classically see. So there can be another reason. Please try to rule out other causes also.
Dr. Hitesh Vora shares a similar case, and he specifies 3 days of fever, malarial parasite negative, dengue negative, urine negative, leptospirosis negative. Patient is still getting fever. So the question is from both Dr. Patil, Madam, and Dr. Hitesh: when should we advise a blood culture? And specifically, is there point in advising a blood culture at 3 days of fever?
Definitely, there is a point, sir. Even if a patient is coming to us with like 7 days of history of fever, getting various treatment at various places, maybe 2, 3 places, some injectable here and there, even then we do blood culture. The chances of having a positive blood culture always remains there. What we have learned from experience and from our seniors is like even if a fever is not responding, if patient is under your care, He's under your care for last 7 days. You are giving different type of antibiotics, and fever is not responding. Please repeat blood culture. There may be some bacteria which is definitely resistant to ongoing antibiotics, and you can find that out in a culture, and probably that will help you out. So definitely send blood culture on your first contact with the patient. There is no point in waiting.
And to complete Dr. Hitesh's question, you answered that already. Not settling down with doxycycline. Empirical would be add ceftriaxone. Last question, Dr. Sunit, the last question, and we apologize for having taken so much of your time today. At the same time, we are grateful. Dr. Javed Ahmed asks, when do you use FFP, fresh frozen plasma? What is the threshold for that in persons with dengue?
We don't use FFP. What we use is STAP, single donor apheretic platelet or random donor platelets. There is no rationale of FFP in dengue. If we are doing it for some bleeding with hepatic dysfunction, then you need to replace your coagulation factor. Then definitely you need FFP. Otherwise, there is no rationale of using FFP in dengue.
So the threshold will be patients with dengue and hepatic dysfunction and bleeding disorder. If all three are together, then
Deranged
FFP.
coagulograms. Deranged coagulograms is important.
Yeah, deranged coagulogram. Okay, so that's the threshold. Thank you, and Dr. Sunit, lots of thanks coming your way. I would add my voice to all the gratitude for having shared your expertise with us. Thank you so
Thank you.
much.
Thank you for inviting.
This is a
And
great
thank
start.
you for being.
This is a great start to our tropical fever series. I'd also like to invite back on stage Mr. Anand Basu, whose idea it was, and I would like to thank Mr. Basu for giving us this idea, also for allowing us to implement it during our season 3 of Diabetes Essentials. Thank you, Mr.
Sir,
Basu.
yes, sir. I think this is a great start because we had a wonderful educator today with us, Sunil sir. Because we, and I think that thanks goes to you, sir, because you chosen the first topic and you chose Dr. Sunit as a speaker. That thanks goes to you, sir.
Always thank you.
Because yeah, because you know him so well, and because he's actually on the job, and the kind of knowledge he brought for all our audiences is immense, and I think that sets the tone for next 5 weeks. And I would request Dr. Sunit that even maybe there may be some question answer sessions where we need again your expertise. I think I would ask Sanjay sir that if it's available on any other coming 5 Sundays, we'll call you, and again because there will be so many questions. We know that we need to get those answers right, sir. With this, I
Thank you
sincerely
so much.
thank Dr. Sunit, and I was just discussing before the start of the session that be prepared for more of question. I was clear that today will be heavy question answer session, so kind of prepped him. Thank you so much, sir, and thank you, sir. Sanjay sir is always there with us, and he will be taking through for next 5 minutes. Thank you, sir. Good night and Jai Hind, sir.
Jai
Thank
Hind.
you, sir. Thank you so much.